So hello, everyone. Welcome to Virtual Grand Rounds. My name is Rachel Bockel, and I'm a second-year medical student at Geisinger Commonwealth School of Medicine in Pennsylvania, and this year's American Academy of Developmental Medicine and Dentistry Virtual Grand Rounds chair. For those that are new, Virtual Grand Rounds are a webinar-based presentation model that creates a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round session is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. If you guys have any questions throughout the presentation, you can write them in the Q&A box on the bottom sidebar, and we'll make sure to go over any of them as we can at the end. And then any questions that we don't get to, we'll post on the website. And without further ado, I will introduce our speaker tonight. Dr. Benjamin Margolis is an MD board certified in neurology and psychiatry, having completed the combined residency program at Brown University. He specializes in neuropsychiatric care of adults with IDD in New York Hudson Valley. He attended medical school at the Albert Einstein College of Medicine after the post-baccalaureate pre-medical program at Columbia University and holds a BFA from the School of Visual Arts in New York City. He is an active member of AAD&D and is working to improve behavioral and mental health care for individuals with IDD on local, state, and national levels. Thank you for joining us today, Dr. Margolis.
Thank you. I just have to start by thanking you guys for the opportunity. This is the community I just have the utmost respect for, and am not accustomed to being nervous to present, but I am, because I just want to offer the utmost respect to the professors, academicians, policymakers, family members, caregivers, docs, and individuals who might be here. And I hope we can be helpful tonight. So I'm ready to start anytime if you'd like to put the slides up so I can control them. I'm not sure how that works.
Just do your screen share again.
Okay, so I hit share screen.
Yep.
And thank you guys for this patience here. Pay no attention to the there we go. Keynote behind the curtain. Is it working yet, or it's not? It's not working?
Just select it from, it should pop up, your presentation if it's up in the background.
Okay, it says whiteboard. It should, but it's not popping up. And sorry, guys. Is that it?
It's just white.
Yeah, a whiteboard. So if you press share screen and then select the screen option.
So we just did this. This is so interesting, is we just did this and it worked before and now it's working again. This is terrific. Okay.
There it goes. Yeah. Okay.
So look at that. All right. So we did the same thing twice and got two different outcomes, and that's not supposed to happen, but all right, it does with technology sometimes. All right. My name is Ben Margolis. I'm a neurologist and psychiatrist. Thank you for the introduction, Rachel. What I'm going to talk about today is going to be very much clinical, very much experiential, and very much targeted to a practical approach. I'm not going to talk so much about epidemiology. I'm not going to give a lot of numbers, and I'm not going to talk a lot about basic science. What I'm going to talk about is what we can do in the clinic. For those of us who don't do this all day, I do this all day. For those of us who don't do this all day, what is an approach we can use when we're not necessarily accustomed to dealing with behavioral care of adults with IDD. And now what do we do, even if those of us who are sort of familiar with it, but don't necessarily manage this in the setting of COVID? What are some of the what are some of the things that we can consider and add to our practice in the setting of COVID-19? So we'll be talking about that starting now. So let's see, I was already introduced. And so I'm currently working in the Hudson Valley. I work with an agency called Access Supports for Living, providing general psychiatric care and neuropsychiatric care to the general population and primarily to adults with intellectual disabilities here in Orange County. Like I said, I have no disclosures. So first, I'll just start. This is a time when many people who have not previously required behavioral care, who have IDD, are coming into psychiatric care for the first time. People have had their routines profoundly disrupted, faced the loss of loved ones, caregivers, peers, been affected themselves. People in congregate settings, people in living with family have faced the same. Day programming is nearly unrecognizable in a lot of settings compared to what it was 8 months ago. These disruptions have led to what we have experienced as a soaring need for care in the general population and also among the IDD community. In light of this, some of the people in our who will be coming into our offices, even virtually, may be new, and I want to give some information to individuals themselves. I'm going to have a segment for individuals, to caregivers, and then to clinicians. There's opportunities for improving care on all these ends. And I have a feeling, potentially, I want to add this caveat that I may be preaching to the choir. I have a feeling that many people in our audience are beyond savvy with the things I'm going to talk about. And I hope you'll indulge me. I hope this is still useful to everyone. But my hope is that there will be some people utilizing this talk who are looking for a place to launch. And so I'm gonna speak with them. Nothing in my talk here veers away from common sense, but as complexity increases, as we're familiar with in this population, common sense principles can sometimes be hard to apply. And I'm hopeful that for people for all these categories of people that find themselves in unfamiliar territory and are looking for a template to providing or participating in this type of care, that this will be helpful. Okay, so today I'm gonna, like I said, provide a framework. I'm gonna give some tools to both family and caregivers. I'm gonna have segments specifically to you guys, and hopefully gonna talk a little bit about empowering individuals with IDD to participate in your own care. So that was the introduction. I'm gonna have a brief segment for individuals with IDD who are seeking or coming into behavioral health care for the first time. I want to address people who are caregivers, family members, direct support staff, people who work with agencies and ComHabs, DayHabs, caregivers for people with IDD. You are on the front lines and can be heroes in facilitating care for the individuals we work with. I know Dr. Rader gives a wonderful talk on the DSP as medical liaison, and I'm going to address some of the same things. And then the remainder of the talk, the bulk of the talk, is going to be a lot for clinicians. Not graphics heavy. I'm used to just talking. So if you want to blow me up on your screen, if that's tolerable for you, you may want to do that. It's mostly text and thought. So with that, we'll get started. Okay. So let's see. The clinician segment I want to say a little bit more about. What that's going to be today is we're going to define the unique challenges around COVID-19. And for clinicians, what we're going to talk about is an approach to the care of adults with IDD. That's going to be a standard biopsychosocial model that you can use as a template for breaking apart problems and coming up with solutions. With all of the domains we're going to talk about are going to be actionable, and there's going to be a separate category for considering what we're seeing in individuals who are recovering from or have COVID-19 themselves. So that's going to be an added consideration and is something unique and new. So we're gonna tackle that first when we get to the clinician segment. But first, what I want to do is talk directly to our patients. I want to talk briefly to any individuals who may be in the audience, or if not, if there's no individuals with IDD who are seeing this, my hope is that clinicians might be able to use what we say, because this is what we do when anyone comes into our clinic, is to emphasize that you will be heard. So I wanted to first introduce that at the beginning of our visits, we should introduce ourselves. These are fundamental things, but maybe less common than we might expect. At the beginning of our visits, we should introduce ourselves and explain what we do. So I want to say, if you are an individual with an intellectual or developmental change that's coming into our clinic for the first time, welcome. We will tell you who we are. We will share with you why you're here and maybe what we can help with. We're gonna talk about some things at the appointment that might be uncomfortable, but you have every opportunity and right to let us know if you feel uncomfortable at any point, and we will listen and adapt. I want to reassure everyone that comes into our clinic that when we're talking about behavioral problems and challenges, that nobody is ever in trouble, that we talk about things that make people feel like they're in trouble potentially, but if we can frame it in a way so that people feel like it's an opportunity to feel better, and that our job is to team up and help get those problems out of the way, it can be a productive visit. I want to just speak to people that come into our clinic, that you are our best teacher. We want to know you, and I want to make sure that we do a good job communicating with you. You have a right to speak during your appointment. We should speak directly to you. If your doctor isn't talking to you, please ask us to. If you don't understand something, please ask us to slow down. If you feel bad about what we're talking about, ask us to stop. If you don't use words to communicate and your advocates speak for you, we're gonna talk about that too. It's gonna be our job to learn to listen to you, but I want to use the next section to talk to your advocates. I want to talk as well to caregivers. So for caregivers in IDD, of course, the #1 rule as a doctor is going to be, of course, we talk to our patients. But in IDD, we all work as teams. This is very familiar. And the following is going to apply to individuals who use words in more limited ways to communicate, or who need supports to convey all the information we need. So, of course, behavioral and psychiatric problems are inherently some of the most complex things we deal with in the world of IDD. They're really hard to figure out. And we have fundamental tools as psychiatrists, behavioral neurologists, neuropsychiatrists. We have the fundamental tools to be able to help manage these things and have the ability to prescribe medications to help. But very commonly, we don't have specific training. I'm very lucky that I came from a place where I got that and where I hit the ground running. But it's very uncommon for us to have comprehensive experience in our training and in our day-to-day clinics outside of specialty centers to be very well versed in the way adults with IDD are cared for. So what I want to say to family members and to support staff who are going to be accompanying individuals to their appointments, I would implore you to team up with us and help us understand how you provide care and how things work at your agency, in your state, with the regulatory agencies that are overseeing your work. In order to assess the problem fully, we need to be able to look at the full picture. So we need not only the information about your agency, but we need a lot of information about the person that you're bringing with you. The more information you can provide, the better served our community will be. So first of all, to DSPs, caregivers who work with agencies, all agencies, of course, have their own individual cultures. And even those of us who do this full time may not be familiar with your particular agency, may not be familiar with your particular ICF, with how your facilities or group homes are run. Everyone uses behavioral clinicians differently. Help us understand what that role is. The role of nursing can be very different. An LPN may be different from an RN at your agency. Nurses have different supervisory roles. Help us understand who we're going to work with to not only get information, but to be able to implement treatment plans. Help us understand who does what. Like I said about us needing to learn about regulatory agencies. Some of us, I live on a border between 3 states, and I'm working with individuals who have 3 different, who may live in my case, New York, New Jersey, or Pennsylvania. Before, when I was training, it was Massachusetts and Rhode Island, and some patients in Connecticut. So help us understand, and that's, that's common because of the lack of providers who do what we do. So help us understand what the regulatory agencies say, how care is deployed, and what some of the considerations that we need to be aware of are when we're beginning to take care of the people that you're caring for. We may need some time to acclimate with that, but we're ready to learn, and we should be ready to learn. So specifically for DSPs, crucial information for providing care for family members, for advocates, for loved ones. When someone is coming into their appointment and they're not able to provide us with information, we can only work with the information we have. So we need the fundamentals. So I listed these things as I was thinking of them, not in order of importance. But one of the easiest things is an up-to-date list of medications. Before getting to know the individual, this is just all of the ancillary stuff that can help us understand who can help as we team up. Who are a list of people working with the individual, and give us their contact information. Who's their behavioral clinician or a psychologist at their day program? Who's the nurse? Who's the manager of their group home? Who are some of the favorite DSPs they work with? Who are the other specialists that they're working with? Does the patient, that can be really, really helpful, because we have to work in a multidisciplinary fashion. And I have to spend a lot of time on the phone with docs and other in other practices. Fragmentation of care is a real risk in this field. And if the left hand knows what the right hand is doing, then it's a much safer way to practice. So if you can let me know who is taking care of the individual you're with, and even give me contact information, I can be a part of coordinating care and be a part of that solution. Who's the person's guardian? If you can, we'll need that information. A copy of their behavior support plan can be invaluable and can be really concrete, a good concrete place to start as we get to know the person and what their problems have been. Like I said before, staff contacts who know the individual best, because very commonly the person accompanying the individual to their appointment is not necessarily the person who knows them best, but the person who's available at the time. So let's bring on board the person who knows the individual best. Of course, a developmental history, a neurologic history, a medical history, a surgical history help us understand who the person is, where they've come from, and the fundamentals of who the person is. Just, you know, what is the person like that we're getting to know? You can help us, along with speaking with them, you can help us learn about the individual that we're learning about. So I like to think of it like when someone is not able to express themselves with words that I can hear yet. Everybody has a piece of a puzzle to help explain a problematic behavior or a set of challenges that we really need to address. A DSP has a piece, the nursing and medical team has a piece, families have a piece, the individual has the biggest piece, but if we put them all together, we can see the whole picture. So we can team up and hopefully hit the ground running together as a team. So then the bulk of the talk is for clinicians. So what we're going to do today is for clinicians, our job is when someone doesn't communicate clearly, to understand the behaviors, understand these psychiatric problems that existed before and that are manifesting now, and it's our job to find new ways to listen. So for what we're going to do today is we're going to review some of the fundamentals. We're going to briefly cover some of the basics of just sort of list together some of the potential pitfalls of neuropsychiatric care if we don't have all of the information available to us. Because what we've seen historically is polypharmacy and things that are really actionable, low-hanging fruit that we can address. So we're going to talk about just some of those things to keep track of as we approach caring for this population. Although I'm given that this is a talk to AADMD, I am fairly sure that that all of the clinicians who may be on board are already doing this. But again, any of us who are new, I'm addressing. And we're going to also cover the adaptations and the added things, like I said before, that we're considering in the setting of COVID-19. So I think that's good. So at the same time as it's our job to listen, everything I talked about before, from when we're talking about to individuals, when I was talking to the individuals, and when I'm talking to caregivers, everything applies to us as well. It's our job to communicate clearly as much as it is to listen. So I just want to make sure that I don't forget to talk about the importance of communicating to the entire team, so that everyone can be on board as we go forward with the plans that we make using this model that I'm talking about in a bit. So what are we seeing now? What's the kind of background that we're facing in the general population and with IDD? So these are new territories and these are uncharted lands, like I said. In the general population, in addition to the IDD population that I see, we're seeing unbelievable challenges and reactions to it. Despair, from lost income and isolation, grieving for lost loved ones, lost social supports, coping with illness of family and friends. We see, the Kaiser Family Foundation did a national survey in July that showed that 53% of adults felt their mental health was negatively affected in the general population by COVID, and that's only going up. Let's see. Anecdotally, what I'm seeing in the clinic is a slow and steady burn as people have difficulty coping, increase in anxiety symptoms, increase in depressive symptoms, even patients with thought disorders and very stable psychotic disorders are starting to have some of those symptoms smolder in response to the stress, even when medication compliance is not an issue. So everyone is being affected by the entire milieu, and I would propose that it's even more significant for our patients with IDD. Let's see. What I want to talk about is, so given that, and given the overwhelming stress that everyone's feeling and coming in, how do we approach people who are coming into the clinic having recovered from or having recovered from COVID-19? Because that's a small and new cohort, and I've got a few of those patients, and I'm seeing both consultatively and then follow up in the clinic in patients. So there's some of those things to think about. But overall, what I wanted to talk about is a framework for approaching the assessment of adults with IDD with new psychiatric or behavioral problems in the setting of COVID-19, with or without a COVID-19 infection. So I'm going to present it as a Venn diagram because that's the way I think of it. And it's an adaptation from the same way to think about CL psychiatry or the biopsychosocial model that psychiatry residents are taught. And it's a simple extrapolation or adaptation from what's already being done in general psychiatry, but we're going to apply it specifically to some of the challenges we see in IDD. So this model is going to potentially guide choices on further testing, identify interventions, depending on what factors might be playing the biggest role. And I'm hopeful that you can actually formalize it in clinic as you approach these cases. Even in our notes, we can use that. So we'll see we'll see the following forces at work, starting with the most novel in this small subset of cases: sequelae, just actual sequelae of SARS-CoV-2. That's new. COVID-19, we are seeing some unexpected long-term sequelae, and those themselves are complex. We're observing them now, and the data's not in yet. It's only been a few months, but we are encountering long haulers, and we can talk about considering that. Social, environmental disruption, difficulty coping, that plays an enormous role in destabilizing people and in some of the problems that we're seeing in clinic. Endogenous psychiatric disease is still out there and still exists. So people still have depression, people still have bipolar disorder, people still have OCD related to their autism, people still have Tourette. Fewer people than carry the diagnosis, have thought disorders or schizophrenia, schizoaffective disorder. It's not as common as their antipsychotic regimens might predict. But endogenous psychiatric disease is still out there. And then, of course, we cannot forget the fundamentals, medical and neurologic drivers of behavior, periictal psychosis and pain, just simple, regular old pain. We can't forget to ask what hurts. So, and in putting all these together And separating out each of these various factors, we can identify targets in each of these domains and be able to help manage them. So, all right, so first, the most novel, what are we seeing as sequelae of SARS-CoV-2 infection? Obviously in patients who have not been infected and who've been fortunate enough to be spared COVID-19, we'll use a tripartite model. That's the standard model that we generally use in approaching neuropsychiatric care of adults with IDD. I'm gonna just take a moment because I had a thought, and forgive me if you'll indulge me. I'm gonna step over here and just I'm gonna make a little footnote. You may say, what is neuropsychiatric about this? This is all psychiatric stuff, and that's true. But I trained as a neurologist first. And we always need to remember these structural problems, these syndromic problems. And I think that that calling this neurobehavioral care with intellectual and developmental disabilities is going to be fundamental. I treat the mental status exam as an outgrowth of the general neurologic exam, and because of the complex and very real interrelationship between neurologic, structural, and psychiatric systems-based issues, it's really, I lump it together as one thing. So if that's okay and you'll indulge me, this is going to be neuropsychiatric care of adults with IDD in the time of COVID. So we'll get back to the sequelae of SARS-CoV-2 infection. The reason I mentioned that caveat there and that brief little footnote and aside is because I am going to talk about some of the just briefly some of the neurologic sequelae that we're seeing in addition to the psychiatric sequelae, because they do play a role. So what are we seeing? So increasing numbers, increasing evidence, initially coming out of Wuhan. Troyer in April published a case series showing that about 20% of hospitalized patients with COVID were presenting with significant encephalopathy. That's I'm not sure at that point if dexamethasone was a standard part of treatment in China. But that was before steroids were a standard part of severe COVID treatment at this point. Severe COVID treatment, but encephalopathy. So confusion, changes in level of consciousness affects about 20% of, initially we were seeing it affect about 20% of people with COVID. Now the number is more, there was a New York Times article pointing to a paper coming out of Northwestern University just 3 days ago, a cohort of about 500 people they watched in Chicago and Illinois come through COVID, and they saw about a 30% rate of encephalopathy, changes in level of consciousness with COVID infection. So now, and then compound that with the fact that dexamethasone is now used to treat severe COVID, and we're very familiar as neurologists and psychiatrists with high-dose steroid. It can be quite agitating. You have like a hypomanic or manic picture, a subset of those 20-something% of people who do develop neuropsychiatric symptoms from steroid can become psychotic. So that's a complicating factor as well, but certainly we're going to see behavioral sequelae, both of the treatment and of the COVID itself. We've seen both large and small vessel strokes in multiple territories, from hypercoagulability associated with, and in young people associated with COVID. So we cannot ignore that possibility as people are treated as outpatients. So sudden changes in functioning, we can't forget the vascular etiologies. People have new onset seizures. Of course, there's a higher prevalence of epilepsy among patients with IDD, but we see new onset seizures, and we can't forget that that's a possibility. And then one of the other most common thing among mild cases that I'm seeing in the cohort that we treated in our group homes was the fatigue and the sleep changes. And then outside of that, in the general population, we see the long haulers, as it were, people with chronic headaches, pulmonary complications, and long-term cardiac sequelae. So changes in energy, I have definitely been seeing in some of the population that has come home from hospitalization in IDD. And those can and have been presented as part of the beginning of the psychiatric visit in some of the people that I've evaluated after discharge from COVID, from a COVID admission. Just briefly gonna, for interest's sake, talk about some of the potential stages or etiologies of the COVID. The neurologic COVID syndromes is first and foremost going to be the systemic, that we'll consider the systemic effects. Hypoxia, just classic toxic metabolic encephalopathies from renal dysfunction, hyperuricemia, hyperammonemia, and of course hypoxia. Hypotension, the classic things that are going to drive things like and hypercoagulability that potentially could drive seizures, stroke, and encephalopathy. The direct neurotrophic effects of coronavirus, which we have some mixed evidence for so far. It's not really showing up in CSF so far, but it's showing up. We found it in some cytosol of frontal lobe neurons, which I kind of hand wave and imagine has something to do with the anosmia and retrograde, neuronal retrograde transmission. Possibly it's hematogenous. It invades leukocytes, and ACE2 we keep reading about as the primary mechanism of entry that the spike protein's attached to. It's expressed on microglia, so we can see potentially a definite direct neuronal involvement. Then there's thinking about the inflammatory cascade that may be a sequelae of the virus itself and directly attack CNS, causing potentially seizures, encephalopathy, and encephalitis. That could also be direct, the direct route, and then also we're seeing rarely. There was I keep quoting popular media. There was I read the New York Times, and I always pay attention to these stories. There was a case of GBS or Guillain-Barré that was recently reported. So the post-infectious syndromes we're seeing less commonly, but we may see Miller-Fisher, BBE, GBS, demyelinating diseases in the PNS or CNS. So all these things are gonna come. But in addition, there is a very clear direct neuropsychiatric, I should say psychiatric presentation to COVID that I have seen a handful of times in consultative work. I've seen two people with some history of psychiatric disease, but no suicidality, and one with no history of mood disorder and suicidality, that in the setting of a COVID infection without clear executive findings, developed an overwhelming urge to harm themselves, and almost an obsessive thought pattern without dysphoria of wanting to kill themselves. Very interesting, and new kinds of things I've heard of, with a colleague of mine telling me they saw from a Lyme encephalitis, like a similar kind of pattern. These are new things that we're going to be exploring, and we need to record and report. Potentially, COVID should be able to, if it is a neurotrophic virus, the way MERS was, or some other coronaviruses are, it should be able, since territory is a key and structure equals function, it should be able to cause both mood and thought disorders depending on where it's active. PTSD is going to be a giant category of post-infectious syndromes that we're going to see. We saw it in MERS in 2012. I never saw a post-MERS patient, but I've been reading that rates are as high as 32%, 46 months out. Of course, we've all seen post-ICU patients with PTSD from their hospitalizations, and I can only imagine that among critically ill or just plain hospitalized patients with IDD, even if they are familiar with being part of the medical system, even if they've been admitted before, of course, medical and syndromic comorbidities are so common, and this is going to be a population that is going to be very familiar with going into the hospital for a procedure, or unfortunately, going in for illness, but never before where your family can't be there with you, never before where you're being treated by people who are wearing masks, whose eyes you can barely see because they're hidden behind a shield. That for someone who doesn't use words to communicate, and whose ability to interpret body language, because they're being treated by people who are gowned and gloved and masked, I can only imagine is an absolute nightmare. So we will, of course, see PTSD. And I have been grateful that some of our colleagues in AADMD have been so active in helping to prevent that cohort. I just want to give another shout out to the wonderful colleagues we have in AADMD who were so active in making sure that legal protections were going to be in place, guaranteeing that that caregivers and visitors had access to need to be guaranteed access and PPE among patients with IDD who are hospitalized with COVID. So just want to give that little shout out. Thank you for indulging me that those two footnotes are aside so far. So let's see. Now we're going to talk about some of the other domains. So we talked about the COVID domain itself, and some of those things that we're going to be seeing that we need to be aware of, and that we need to make sure we address. The unbelievable and profound dysregulation in everything we knew before is only more so impacting our patients with IDD. So what are some of the things that we can ask about as we're getting to know somebody and looking at behavioral or emotional dysregulation? Some of the things we can keep track of are, okay, so what are the disruptions in their regular staffing? Who's taking care of them, and why is it different? It's going to be hard to get to know somebody new. Staff and family illness, that's going to be an enormous stressor for the individuals that we're working with. And sometimes they may express it in very dramatic ways. Disruptions to scheduled visits home. That's been one of the biggest drivers that I've seen in my clinic so far of elopement behaviors and sometimes driving property destruction. The disruptions to scheduled visits home, we have to be sensitive to, and there's obviously things we can do to address that, to predict and create a regular schedule around, Zoom and FaceTime, and these tools are a godsend for managing that. disruption in day programming, not getting to see your friends anymore, not getting to do the things you like to do anymore, not getting to see the staff that you're as close with as your family. All of this is tremendously destabilizing. In addition to not having anything to get up for, can create some sleep dysregulation that can drive some mood destabilization. So we're seeing that, and that's certainly something we want to deal with. Cohorting stressors. Just like the disruptions in the regular staffing, we're seeing patients go home and stay with family, and that's really different. If you love your house and you want to go back to your house, but you've been brought home for safety, understandably, or sometimes there are family stressors at home that have been quiescent for years because people spend limited time at home. Suddenly they're with their families, and that sometimes has dynamics that we can address and improve. But also sometimes you may need to have a new housemate, or you may be in a new house because the house because of cohorting stresses, just from house being reassigned, because of house being needing to be used for COVID positive patients, or for hospital discharges, depending on the way an agency is managing their cohorting needs. Response to caregiver stressors. Caregivers right now, there was a paper in Jared, the Journal of Autism Research and Applied Research in Intellectual Disabilities. I'm sorry, it's a British paper from I believe May or June, that showed that in surveys among caregivers, it was in Britain, but among caregivers, comparing caregivers of children and adults with medical needs versus children and adults with intellectual disabilities, and specifically the equivalent of DSPs, stressors among staff were much higher in realms of depression, anxiety scores, difficulty coping, and we have heroes risking their lives, staying away from family in order to, or quarantining in order to care for individuals, working extra shifts, going through various stages of quarantine, managing fears of who's going to take care of my kids when I'm taking care of the people that I'm serving. So that can affect everyone, and that's not said with the intent to make a caregiver feel any more responsible for the well-being of the individuals they're serving. I say that as a reminder to caregivers that you are considered and that there are resources available for you to help. Those specific resources are not necessarily the subject of this talk, but I want to put a pin in that in case those resources are needed, because we can make sure to have a follow-up to, and especially because those resources are going to vary by city, state, and county. But to say that caregivers need help too. So I hope that list is not misconstrued in any way. Masking and distancing, lack of facial cues are new. When somebody relies on a facial expression, if they have a sensory impairment, again, we talked about the unbelievable stress of being hospitalized and feeling like you're on another planet. If you have that at home as well, and you can't tell what your caregiver's facial expression is, that can be tremendously stressful. The need to suddenly social distance and not be able to be close to the people you love, the requirement to wear a mask, these are really hard things. Anyway, and the point is the honeymoon period is over. So, we saw that initially when this happened, people kind of the novelty was protective to some extent, but now we're seeing that these stressors are ongoing and wearing. Endogenous psychiatric disease. I'm going to race through these now because I thought I was going to get through this in 40 minutes, but there's a lot to talk about. So endogenous psychiatric disease still exists. So I wanted to give a couple notes about just making sure that we as psychiatrists, as family docs, as neuropsychiatrists, as neurologists, we have a familiar pharmacopoeia that we know how to use fairly well to manage some of the challenges that we're talking about. I'm going to talk a minute. The specific pharmacopoeia and the specifics are beyond the scope of this talk. But just to say that the endogenous psychiatric disease is still out there, and remember, comprehensive information yields diagnostic accuracy. Get all of the information and get a full picture before we write a prescription, and make sure that we connect every medication to a diagnosis all the time. I mean, of course, it's hard being a prescribing clinician when the only drug that's FDA approved right now for aggression related to autism is risperidone. Everything else is off-label. But even if we're being off-label, we can be clear about the fact that we're being off-label, and we can still utilize some of the tools like neuroleptics when we need to support an individual, but connect every medication to a diagnosis. That can avoid medication snowballing and accumulation. That can avoid diagnoses attaching to someone like barnacles and being with them for the rest of their lives, and can avoid polypharmacy, because that can, just the simple act of connecting a medication to a diagnosis can remind you that you may want to pull back on that medication. When we pick up care of someone with IDD who's on 12 medications, we can ask ourselves why, and we can see if maybe they do need dual antipsychotic therapy, and get information from all of the available sources to be able to look at that. And then also Dr. Craig Escude, who is a wonderful colleague and gives a similar talk. I think a lot of us have talks like this, and his is excellent. And I want to give a shout out to the point he made, another AADMD colleague, about asking, is this a psychiatric disease or is this a behavior? Are we medicating behavior? And if so, is that maybe in this time appropriate? Maybe maybe in this time, I would propose that although we never like to medicate behavior, in this time of COVID, we may have a different conversation about PRNs when it comes to being able to attend your appointment or get lab monitoring done. If you can't participate in masking and participate in the necessary social distancing. Of course, we're going to make accommodations. We're going to try and get home lab draws when possible. We're going to maximize the use of telemedicine. But I think that it's a really important thing to reconsider how we treat our PRNs. Making one change at a time is going to be absolutely fundamental when we're prescribing. And not making, unless there's a medical reason to, not making dramatic changes in the first place to avoid withdrawal dyskinesias, withdrawal dystonias, discontinuation syndromes from SSRIs. Maybe someone has no history of epilepsy, but they're on a mood stabilizing anti-epileptic drug. Think about what changes you're making, both from the benefits and from the risks, as we go through that process of remembering to connect every medication to a diagnosis and reconsidering whether we need them. Let's see, and then also just specific challenges. We talked about the monitoring challenges, getting your lithium levels, getting your ANCs for clozapine, and in this time, especially now that it's a possibility to use telemedicine so robustly, I would be more liberal about follow-ups. Because while I feel really good about the fact that among the general population, it may be very difficult to screen for regularly for anticholinergic side effects of clozapine for serious constipation. In addition to the fact that they are monitored, more closely in congregate that our patients are monitored more closely in congregate settings. That given all of the factors that we're talking about in the stressors, patients with IDD warrant more frequent reassessment and follow-up, especially in this time of COVID-19. That's just a best practice suggestion. I don't have evidence to back that up, but I have a hard time arguing against it. Okay. Again, I said that specific treatment algorithms are beyond the scope of this talk. Medical and neurologic drivers of behavior we cannot forget. So the fundamentals, cannot forget the fundamentals. The fatal five, you know, they're different in different settings. There's different lists that different areas use, but fundamentally, we can't forget that aspiration is the #1 cause of death in an individual who lived in a congregate setting. Infection can present behaviorally. Constipation, bowel obstruction, ileus. Seizures are still a risk. Periictal behaviors, dehydration. Remember the fatal five. Remember to ask what hurts. We talked about specific challenges related to the time of COVID-19, limited access to labs potentially, lack of ability to do in-person follow-ups. I talked before already about the new conversations being warranted about PRN medications to facilitate monitoring. But in addition, as wonderful as telemedicine is, not being able to perform a physical exam as often can create its own risks. So we all have our stories about forgetting the fundamentals or of where we learned the fundamentals. A patient with a UTI that ended up treated with a neuroleptic. I've seen otitis media presenting with in a patient who was hospitalized inpatient psychiatrically and wasn't responding to any medication, and then their tympanic membrane finally perforated, and suddenly they weren't a psychiatric patient. You know, we all have these stories, but the risk is potentially higher during this time. And that is a risk of telemedicine that we can't forget. So we have to make sure that we are absolutely comprehensive and multidisciplinary during this time. So then putting it all together, all of these things together are all potentials for actionable items that we can utilize in the clinic. We can make our problem list based on this domain-based thinking. And I think that that putting it all together is the most comprehensive way I'm aware of at this point. Although this is a proposed model that I'm using, and of course it's just an adaptation of the classic biopsychosocial model that we use for care. I think that it will serve us all well to utilize this framework. Putting it together. Also, so what do we do? Just we treat our endogenous psychiatric disease. We consider utilizing social and environmental factors, supports in new ways. We utilize technology. Our behavioral staff have put a lot of thought into this. The Special Olympics have gone mobile. There are resources that we're adapting, and we need to team up with our behavioral colleagues to be able to apply those. In terms of the sequelae of SARS-CoV-2 infection, COVID-19 related psychiatric disease, we don't have evidence. As long as we remember to adapt our dosing for changes in GFR and hepatic function and changes in weight. Continue to treat our endogenous psychiatric disease with adapted dosing, perhaps, or increased monitoring. And then the sequelae of let's say it is a post SARS-CoV-2 PTSD. How do we treat that? Evidence says use your first-line therapies. We don't have anything that says you shouldn't necessarily use that. Delirium, we should treat as we always treat delirium with the same tools. With applying this framework carefully, we will be able to hopefully suss out and identify delirium / encephalopathy. we can use in a separate, if someone's not already on neuroleptic, you can use low-dose Haldol Seroquel neuroleptic at low dose for a limited time to manage delirium, while it won't necessarily reduce the duration. It can reduce the severity, and then of course paying attention and addressing our medical and neurologic behavior, drivers of behavior. So these are new territories, but they're actionable. We can help. There's things we can do. We can prevent our teams being divided. The more we communicate, because disagreements about the etiology of some of these problems can happen in these settings. But the more we communicate, the more we can persevere and all come through this together. So anyway, I don't know if there's time for questions. I did take the hour. I'm sorry. I thought I was going to go 40 minutes, but anyway, that was great fun. If there's any questions, I'll leave it to Rachel and Courtney to be able to connect us all.
Thank you so much, Dr. Margolis. Yes, we do have some time for questions. It's okay if we go a little bit over time. So our first question is, they want to know more about the treatments of respiratory disorders in people with IDD.
Sorry?
So the person asked to describe more of the treatments of respiratory disorders in persons with IDD.
Oh, so I'm going to defer actually to my wonderful medical colleagues as a neurologist and psychiatrist. What I can say, I'm going to kind of pivot a little bit, and I can say that we are going to very carefully reassess upon discharge. And if someone is on a medication that could potentially suppress respiratory drive, although I don't see opioids commonly used in this population for pain management, fortunately or unfortunately, depending on the setting. We do see benzodiazepines used really frequently. So reassess our benzos in the setting of a discharge, reassess our medications that could potentially suppress respiratory drive. But I am going to defer any questions about respiratory questions to some of our other brilliant AADMD colleagues who have really robust answers for you.
Great. Okay, so another question we have is asking about the sequelae. So is the sequelae long-term, and specifically neurologically, is it long-term?
So it all depends. So some of the, I don't have follow-up on the patients that I mentioned who had this, the suicidal ideation, because I saw them at a consultative, in a consultative setting. So I don't know yet. The data will show. Certainly strokes are not necessarily reversible, but you tend to see like a sort of healing process over the first 6 months on the whole, and then as adjacent areas of cortex and brain kind of take over and can do what the affected areas of brain used to do, and then that can kind of come and go in the setting of illness or fatigue, and they call that like a revisitation syndrome. So you can see after stroke function come back and heal, and then in the setting of illness it can go away. But in the setting of the encephalopathy or the prolonged delirium, I have seen improve. I have not seen long-term encephalopathy or delirium. I don't know. The evidence is being accumulated now. As far as PTSD, that can be very long-lasting. As far as demyelinating disorders, as far as the sequelae or long-term sequelae of an encephalitis or an encephalitic-like picture, that's going to be quite variable. but at this point, I can only say that that in terms of PTSD, it's going to be long lasting. In terms of COVID-related stroke, that's definitely going to be long lasting. And in terms of the other sequelae of COVID, we're waiting to see, and we will learn together. And it's really important that all of us team up to make sure to record and carefully record our observations, carefully observe, and we will be able to report them together as time goes on.
Great, thank you. We have one final question. So this question is, can this population outgrow a diagnosis as they get older? For example, pica, is that outgrow?
That's a great question. So pica is a complex behavior, and again, this is going to be a separate and very interesting talk. I feel like each one of these topics is going to, especially over time, the long-term sequelae of COVID is going to be its own talk, or maybe full day of a conference. But pica is a really interesting and multifactorial behavior. There's several things that can be driving it. So depending on what's driving it, it may wax and wane, or it may completely go away. But the behavior itself of seeking behaviors, seeking non-food items, and or just depending on if it's sensory and if it's just putting something in somebody's mouth, that I can't answer unless we talk about specifics, but it's a really interesting question, and allows us, if we were to dive into that, let's say like pica was the problem, and there was a person who was who never before was putting things in their mouths that was dangerous, or we needed to intervene. This is something that we could really launch from and use all four of our categories for. Is this an old behavior that's coming back? Let's ask a bunch of questions together, figure it out, and potentially, yes, potentially somebody could outgrow the diagnosis, or potentially someone could outgrow the problem, or maybe not. Let's figure it out together. So that would be a sort of non-answer answer, if that's okay. Yeah.
Yeah, absolutely. Yeah, that's all the questions we have. I think we have one more final slide to show that Dr. Keller will speak on.
Hi, very much. Ben, I wanted to thank you so much. I, as you, I'm a leader in this field, and we're learning, right, on what's happening with COVID-19. And it is so amazing, though, that you're bringing this issue to this much attention, because I feel, right, I mean, how much do we know? I mean, all this we hear, we know, we suspect, and I think this is something that is so valuable for all those that care and support this population to really listen to this information and know. And it's an amazing segue, Ben, because we are at the same time putting on this effort, Our Stories COVID-19. And it is really, in much respect, trying to even collect the stories of the perspectives that you are talking about tonight, Ben.
Wonderful. Yeah, please, if you want to invite people to COVID stories, I didn't want to.
No, I am. That's it. You got me, because that's exactly what we want to do. Because the point of COVID-19 stories is really to try to really get a sense of what the people that we know and care and support are living their lives. And it doesn't necessarily have to be a tragedy or a terrible story. It could really be one of inspiration or resilience, how people rise to the occasion, but also the truth of the difficulties that many people are having, just like you were talking about. So really, our COVID-19 story is a really event connected to so much that, that Ben talked about. And this is access, as you can see by this information. We're going to have a launch party that's going to talk about it. And we've already collected a number of stories, and it's something we all want to learn from. So thank you very much, Ben, for really putting on a great talk, and this issue of knowing all this, hopefully by the stories and getting together. Maybe we'll even do a research study. How about that? We need demographics, right? We need data.
Yeah, well, this is the right group of people to do it. So.
Well. All right, Ben, sit down. I got a job for you. I'm just kidding. Anyway, thank you very much. Thank you.
Thank you guys so much. Thanks, Ben. Thanks, Seth. And I'm going to go ahead and end it right here. But thank you so much. Wonderful job. Wonderful. Cannot thank you enough.
Thanks, guys.
Thank you so much.
Bye.
Good night.